Dr. Costache will speak of aortic dissection with multi-layer stent. Victor, you have 10 minutes.
So treatment with 10 years of follow-up of this disease. Many cases are similar to EVO with a common project, no conflict of interest. So you see it works. So this is recent data from IRAD. So if you do proximal stenting with stent graft only and short stenting, this will never work when you treat aortic dissection because 62% of patients will develop thoracoabdominal aneurysm at 5 years, and that's not me saying, it's the IRAD, the International Registry of Aortic Dissection. So 10 years ago, I started using multilayer stent in aortic dissection, and this is how they work. So this is rare footage of transesophageal echo before and after multilayer stent implantation, and you can see how this stent works. It will reopen the true lumen, and this will maintain side branches perfusions. So when are they effective? They are effective in both type A and type B aortic dissection. So we will move on type A. So what's important in type A is to replace the ascending aorta, of course, and then you will have a lot of scenarios. So after using multi-layer stents, we did the first case in 2015, and we've published the first case with complete remodeling in 2016 in Journal of Vascular Surgery, and then in 2018 we have published in Annals of Vascular Surgery the kinetic elephant trunk technique for combining multi-layer stent surgery and multi-layer stent in aortic dissection. So these are two of my longest follow-ups, up to 8 years. So this is a gentleman who has, you see, after surgical correction, he has a residual thoracoabdominal dissection with big entry tears at the level of the arch, descending aorta and extending to both iliacs. So you see the big entry tear in the arch. So you could either do EVO's technique that you saw, or you can use a multi-layer stent and implant it in the ascending aorta and going up to the iliacs. And this is the CT scan. So here, Peter, I need your help. If you can go every 10 seconds. Yes, good. So here, just stay like this. You see the multi-layer stent at 8 years is effective. It occluded the side, the new entry tears in the arch. And you can see nice remodeling in the thoracoabdominal aorta. No residual aneurysm. So this is where usually people who do stent graft click and they move forward because they have a disaster, a big thoracoabdominal aneurysm. So here, no aneurysm. If you can go lower, 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 and you see complete remodeling towards the iliac. So another patient, 56 years old, that I treated in 2015. So after ascending aortic repair in another center, she had complete arch dissection and even post-anastomotic aneurysm, big one. So we did redo ascending aortic and arch surgery, and then multi-layer stent, and this is her follow-up. You can go a little bit further. Please, Peter, more. So you see, very nice remodeling. So what about type B aortic dissection? I moved to type B for the sake of time. So the majority of patients were included, my patients and Ivo Petrov's patient in the Dragon study, which was a prospective multicentric international trials. We have treated 20 patients of type B aortic dissection, and we have recently reviewed those patients. So this is population baseline with the majority of patients being male hypertensive, and these are our results. 2.5 aortic stents implanted per patient with a high technical success rate of up to 95% and a mean of 7.1 major aortic branches covered. About the patents in 98% of branches were covered, with a total of 100% branches patent at the level of lumbar intercostal arteries. So this is why we didn't have paraplegia in any of our patients. During the study, we had estimated 5-year survival of 90% of 5 years and a mean survival of 69 months. So this is what a typical follow-up looks like in a type B aortic dissection. On the left, you see the type B aortic dissection, and on the right, you see the remodeling achieved at 52 months. There is always be a little flow in the remnant flow in the false lumen, but it's tiny. It's for lumbar intercostal artery, lower arteries, and it's not going to become an aneurysmal. And that's our longest follow-up, 56-year-old patient. We treated in 2015. In 2018, we've published complete remodeling for this patient in GAVT. And this is his longest follow-up in the world, 10 years of follow-up, complete remodeling. The patient is doing great. So these are our global results for this study: 95% success rate, 90% 5-year survival, no ischemia, no paraplegia. And this was published in actually in January in 2026 in GAVT. What does this number mean? So if we compare in blue, light blue, these are our results, and in red, these are the results with the best you can get with stent graft, classic treatment. So the survival is better at 5 years with multilayer stents, freedom from aortic growth, it's better, and freedom from reintervention is better. So what are the perspectives? Perspective number one, combining multilayer stent with stent grafts. So we have done such a case. You can click play on the, Peter, please, on the video. Yes, excellent. And go a little bit further. So complex type B aortic dissection, as you can see on the pre-op, and we have used Medtronic stent for covering the subclavian and proximal thoracic aorta, then multilayer stent, and there on the CT scan you see the interposition between stent graft and multilayer stent, and then multilayer stent till we did a syrup with stent graft, and we have achieved complete remodeling with excellent side branches patency. Second perspective, frozen elephant trunk technique. So we use frozen elephant trunks for type A aortic dissection or for non-A, non-B dissections, and we have the largest series in the country. So when you do this, even after a very successful frozen elephant trunk, you still have distal dissection, like here, you see, distal dissection, and these patients are not going to do well in the long term. So this is one of our cases where we have combined, you see it's a typical non-A, non-B dissection with a big entry tear at the level of the arch. You can see it here, huge entry tear, so very dangerous form of dissection, and it's dissected till the iliacs. So in this case, we have done frozen elephant trunk. As it happens, sometimes frozen elephant trunk didn't open, and we put a multi-layer inside on an emergency basis, and you can see excellent remodeling, frozen elephant trunk combined with multi-layer stent going up to the thoracoabdominal aorta, excellent remodeling. I think it's a solution for this disease. EVO have published recently that it's possible to cross the mesh in this stent because some people were concerned. And this is the data that we have right now with multi-layer stent. There are around 100 patients treated all over the world with multi-layer stents. We have done the first cases with EVO, and right now there is the extensive study going on in Europe with big centers like Pitié-Salpêtrière, AKH from Vienna. The steering committee is Dr. Nienaber and Professor Alsac from Pitié, and me and Professor Petrov were part also of this study. So, ladies and gentlemen, these are our conclusions. Long-term clinical and CFD data confirms the durability of this new form of endovascular treatment for both complicated type B aortic dissection and residual aortic dissection after type A surgical repair. Faster aortic remodeling is achieved when combining multilayer stent grafts with stent grafts and frozen elephant trunk hybrid grafts. Of course, further studies are needed to confirm the role of these new generation flow modulating devices in the management of aortic dissection. Thank you very much.
Thank you. Thank you very much, Victor. I have the same question that Frank asked a few minutes ago. what is the current situation of the multi-layer stent and TRESA, and is current availability for everybody?
So that's an excellent question, and this was the subject of my last two slides. So I will be less subtle. So after me and Ivo promoting this technique and showing our long-term results, now the big boys are running the studies. So you have Christophe.
Are you waiting for some authorization in Europe or in France?
Well, actually, the study started. The patients, all of the authorizations are there. First cases were performed in Germany, in Austria, in Serbia by Igor Končar. He performed the first case in January. And we are still waiting to get our final authorization in Romania. I don't know what's the status of Ivo bureaucracy, but many people are starting it, and I think it's good.
Do you think that this product could be reimbursed in a certain country, and at what price? Can you imagine something?
Of course, it's like all endovascular stents. So for example, in our countries, all stents are reimbursed. So there is no issue about this. I have no idea because I'm not selling this stuff. So,
I think it will be around 5,000 euro, probably.
Yeah, it shouldn't be very expensive.
Victor, you mentioned in some cases combining standard stent graft proximally with this multi-layer stent distally. Why would you do that?
Well, so for example, you can have a high velocity entry tear proximally. I think they will remodel quicker with closing that big entry tear, because the aorta, we know it's not the same proximally and distally. They have several different embryological origin. They have
so you're saying that because a multi-layer stent does not close,
of course,
the entry tear.
You shouldn't use the multi-layer stent to do rupture cases or stuff like that.
No, I understand that.
Yes, but when you have an entry tear proximally in the arch or proximal arch, I think you will be more effective with a stent graft.
Because of the closure of the entry tear.
Because of the closure, you will have immediate closure of the entry tear. However, you've seen, I've showed you the case with the big entry tear at the level of the arch, and the multi-layer stent stabilize it without any issue. But I think it's safer when you can put a stent graft there to use the stent graft there. So I think it's a very useful endovascular tool, and you have adapt to each patient to see what stent you will use. For example, you have a frail patient, you can't do what Ivo is doing, or you can't do a frozen elephant trunk for the arch entry tear. So it's well, a multi-layer stent will be better. Total multi-layer stent will be better. But what's sure, Frank, that for distal thoracoabdominal dissection, you have no other options. You have nothing.
Victor, thank you. I have some information. The session will go on, but with new moderators, we can quit the podium. And are you moderator? Can you moderate and start the TEVA symposium, and Boehringer also? Ladies and gentlemen, I think we are going on with Klaus Mathias, and we will come back to the live case just after, so we will have some more time. Klaus Mathias is from Germany. He will speak of aortic stenosis. Klaus, you have 10 minutes.
Okay, so please show my slides. Oh yes, here we are. Yes, so endovascular treatment of abdominal aortic stenosis and occlusion. And yes, what is the gender effect? That was something which was a little bit surprising for us, because with peripheral arterial disease.
Timer, please.
men are leading, but with aortic stenosis, yes, we have seen more women than men with occlusion or stenosis of the abdominal aorta. And you can speculate why that is the case, yes. Perhaps it is that there are different shear forces, so we have more men with iliac artery disease, but because the aorta, the distal abdominal aorta is much smaller in women, therefore perhaps they have a higher risk to develop their atherosclerosis. I don't know why it's not functioning.
Next slide.
Yes. So we have naturally also surgical treatment of this, but there we have also complications and mortality rate. Yes, you know that, and therefore when we can deal with these problems endovascularly, that has quite some advantages. So that is surgery, but we do that now not open, but endovascularly. We have large balloons for that, and we have also, because ballooning alone is not sufficient, we have also other devices which we will use, especially in calcifications. It's not, I don't know, it's not running smoothly. So yes, we have different endografts now available for that, and we work with them. And yes, now it's running without my doing. So a little bit unusual. So I like the Bentley B graft for this purpose, to deal with these aortic lesions. I don't know why I have these device. It doesn't work, yes? And you see here a typical lesion. It's below the origin of the renal arteries, a calcification, as you see, and then you go up there. There's also another problem, as you see in this lady, because she has also catheters there in her Go to the next. I will always now say next. And here you see another example here. Yeah, that is dead. And so, next, you see that we have a really good result with dilatation in combination with endograft placement. Next. Another case is also the iliac arteries are not so good. It's a 53-year-old lady, and she had there also this lesion in the distal abdominal aorta. Next. Next. And you see also a fairly nice result after endovascular treatment. Lesion removed and normal flow. Next. Yes, that's a 70-year-old lady. Yes, again, eccentric lesion there with ballooning and endograft placement, also a good result. Next. Here again, yes. 50-year-old, again a lady. Yes. Next. Also fine result. So with these endografts, we get really good results in a combination with ballooning. Next. Yes, you see here again, another case, yes. Again, a lady, 47 years old, so not so very old. Next. And you see how we worked on that, and we could improve it, so she was, after the procedure, she was asymptomatic and could walk unlimited. Next. That is the result of the treatment. Next. So to come to the results, yes, you've seen that we had a follow-up of several years, but on the mean 2 years. And as you see, yes, 46 women and only 15 men. So there is a gender-dependent, yes, factor there. And also you have not to be very old. It can also start with these in the ladies in their 40s. Technical success rate is high. We are lucky we had no distal embolization. Recurrent stenosis in one patient where we did a second intervention then to remove the stenosis. No stent fractures, no aortic rupture. One patient died, but not due to the intervention, but due to coronary artery disease. Next. So summary is, yes, 3/4 of them were female patients. All patients were smoker. Treatment with a stiff and strong endograft delivers good long-term results. And thank you very much.
How do you explain this predominance of the feminine?
Therefore, I thought, if that's true, I don't know, that men have their problems more in the iliac arteries and women more in the distal aorta. So perhaps it's due to shear forces and other things. So.
Can you explain the rupture? Do they oversize or too much, or what? Or is it necessary to put a stent graft directly?
Yes, we do these interventions in local anesthesia. So when you overdilate, when you do it very slowly, the dilatation, then the patient will complain of pain. So respect the symptom the patient will tell you, and don't overdo it. But as you have seen in these examples, yes, normally you get a normal diameter.
Frank, you have the experience of such a technique. What is your comment on this series?
I don't have a comment. Thank you very much, Klaus.